Thanks very much, Bill. So it's now my pleasure to introduce Beth Lown. She's the medical director of the Schwartz Center for Compassionate Healthcare, which is dedicated to strengthening the relationship between patients and clinical caregivers. Exactly what we've been talking about. She's a primary care physician, and she's on the faculty of Harvard Medical School as an associate professor. Beth.
Thank you, Vikas and Shannon. Welcome. We have a wonderful panel here to kick off our discussion about malpractice today, which is a topic that does engender some fear and loathing in some of us, as the panel title suggests. I'm going to introduce our panel, and I'll make a few framing comments to get us started and then turn the discussion over to our panelists. But we have with us today Dr. Max Borton, MD, JD, and partner at the law firm of Gorvitz and Borton. Max has argued successfully for the Supreme Judicial Court of Massachusetts and has been in his past life a previously practicing OBGYN with many, many years of clinical practice and teaching experience. Bill Mykrantz, primary care physician and medical director of Cambridge Family Health. He's also an instructor of medicine and pediatrics at Harvard Medical School, and he is also a bassoonist. And we have Jerry Hoffman, professor emeritus of medicine and emergency medicine at UCLA and former chair of UCLA's doctoring curriculum for medical students. So I'd like to just set the stage for a few minutes by summarizing what I've learned about malpractice. And then I'll turn the discussion over to the panelists. It is estimated that the annual medical liability system, including defensive medicine, costs about $55.6 billion, about 2.4% of healthcare spending in 2008 at least, when that particular study was done. And just by way of definition, defensive medicine includes two buckets or categories of behaviors. There's assurance behaviors, which is ordering tests, referrals, procedures that are not clinically necessary. And there are avoidance behaviors, which means when physicians choose to stop doing procedures because they perceive them to be risky or choose to stop seeing patients whom they perceive to be potentially risky. So who sues doctors? A lot of people suffer injury, as we well know, but very few people sue. The probability of a claim after a compensable event is about 2% in this country, and it's 2.9% in New Zealand, which has a no-fault administrative malpractice compensation system. And in both countries, the people who do not usually sue are members of underrepresented minorities, they're the elderly, and they're the poor. When people do decide to sue, if you ask them why, invariably it's because they have felt disrespected, dismissed, felt that their concerns weren't elicited or attended to, they couldn't get their questions answered, and they overall came to feel that someone was covering up something bad that had happened. It's also known that a very small group of physicians are the people who do get sued. It's about 2 to 8% across professions, and that this risk seems to stay fairly constant per physician over time. What was interesting to me to think about, there was a study that Robin Tamblyn did that showed that physicians, or at that time medical students, scores on the United States medical licensing exam, step 2, where you have to demonstrate proficiency in communication and physical exam skills. Poor performance on that part of the USMLE exam correlates with retained complaints to medical regulatory authorities. So it's possible that this risk is predictable as early as the 3rd year of medical school, but it's not addressed. At the same time, we know that when physicians are surveyed about defensive behaviors, the assurance and avoidance behaviors, the vast majority of physicians say, yes, they've practiced these behaviors, even though it is completely uncorrelated with personal experience or exposure to malpractice. So we have a collective anxiety driving these defensive medicine behaviors that would be really interesting to pursue in this conversation. The trouble is, the more we practice these kinds of defensive behaviors, the more likely it is that they become legal standard of care. So I'd like to ask our panelists to begin their comments, and we're going to ask Max Borton to begin, if you'd like to come up to the podium. I'll move this.
Good afternoon. Can you hear me? This reminds me a little bit of an Argentinian saying that is, when it will be raining soup, I will be standing with a fork in my hand. And I say that because here I am invited by the Lown Institute, premier cardiology institute in the country, and I can't tell you how many times I was told I don't have a heart. So it's interesting that as a lawyer, I go first. Usually we come last. But I have 35 years of clinical experience, and I was told I didn't have a heart when I was teaching residents. So let me make a few points that I have gathered from reviewing many, many medical records. We reject about 29 to 30 cases for every case we take in our office. It's extremely expensive to prepare a medical malpractice case. It's in the average of $70,000 to $80,000. The score in Massachusetts is that from cases that go to court, 94% go for the defendant. That takes into account that before, not all cases that are filed go to court. A lot are settled by mediation or in other forums. But let me tell you one case that will illustrate a lot of the things that I wanted to cover, but in 5 minutes, there is just no way. So if there is a chance, I'll talk about it later. This is a 11-year-old boy who goes to a hospital and gets an appendectomy. Stays in the hospital for 2 days, laparoscopic appendectomy, and upon discharge, the surgeon notices proteinuria, over 300. And the surgeon writes a 2-page note to the primary care physician. Now, I practice GYN, so I did surgery. I dealt with surgeons. Surgeons don't talk, don't try, they bark. So when a surgeon writes a 2-page referral letter, you better read it. Well, the letter had about 12 paragraphs, and somewhere in the 7th or 8th paragraph, it said to the primary care physician, "We discovered proteinuria, please follow up." I doubt that the proteinuria is due to urethral inflammation by the appendix. I think something is going on. The primary care physician initials both pages and files it in the medical record, sees the child for 4 years, and then leaves the practice. Another primary care physician comes in, reads the records, and says, "Oops, we didn't do a renal function on this kid," does renal testing, and it comes back with a microalbumin of, 23,000. It was outrageous. And the child is now 15 years old. The primary care physician sends a letter to the child, not to the mother, to the child. The letter comes back unopened, addressee unknown, and the nurse practitioner tries to get in touch and doesn't get in touch with the mother. Now, the child comes back to the practice about 6 times. Sore throat, earache, this, that. But what's interesting is a year later, comes back to the practice for an annual and gets a complete physical, and it's a 2-page write-up. And the same physician that wrote a letter saying, go find yourself a nephrologist. That's what the letter said. Your tests are abnormal, find yourself a nephrologist. Sees him a year later and writes, everything is normal, you can participate in competitive sports. I don't have to tell you the end of the story. A year and a half later, the child is in total renal failure, gets a transplant, is now committed for life to future transplants and to more medication. So we filed litigation, and we deposed the first primary care physician. And as strange as it is, and I have to tell you, I have an associate usually with me during depositions, and I always, when I turn around and I says, get me some Motrin, she knows that I'm in a lot of pain. Because sometimes it's so painful to hear answers. This primary care physician, after acknowledging he signed the letter, he initialed the letter, says, look, I'm so busy in my practice that I only read the first paragraph and the last paragraph of the letter. First paragraph tells me why he's sending the letter, the last paragraph, what the recommendations are. I did not read the entire letter. I let you decide what the outcome will be for that physician. Then we deposed the second physician, and I said, doctor, you sent a letter to a child. It comes back unopened. You see the child several times. Well, I was seeing the child together with the other brothers and sisters, and I was seeing them as a family. I said, but a year later you saw him for a complete annual exam. Did you read your old medical record? I don't have time to read my old notes. I let you decide. It's a problem. Most medical malpractice cases are physicians taking shortcuts. It has nothing to do with bad people, bad lawyers, or, it has to do with physicians taking shortcuts. And I will close by saying, when I was practicing obstetrics, we knew that X number of complications will show up on day 3, 4, and 5 after the delivery. They're well known. So when they decided to send patients home on the second day or on the first day, I was raising a voice saying, you know you're going to miss complications on day 3, 4, and 5. Well, that's the chance we are taking. If you're taking chances, go on and pay the piper and keep on going. But the idea of we want to take chances with the patient's health, I think has risks. And it's like driving in Boston. You know you're going to get hit with an accident, so, get your insurance and let it run. I think I went over my time, and I have more points, but anyway, I'm here for you to shoot questions whenever you feel like it.
Thank you, Max. Thank you.
As soon as I get back to the office, I'm checking my in-basket for unread letters. I'm a primary care physician, and I guess I'm representing on our panel today the point of view of someone at the front lines who's under a lot of different types of pressure. If I sit down in a room with a patient who comes in with a cold and has a cough, there's a lot of other people sitting in that room with me. There's the medical director of my IPA, who has let me know that our group does not have enough bronchitis diagnoses to go in the denominator in order to qualify for our quality measure. There's the quality manager for our ambulatory service and the number of throat swabs that need to be done if somebody is presenting with a pharyngeal complaint. There's the patient's insurer. There's perhaps even in a real way the patient's family, who are living in the narrative that doctors make mistakes and it's your duty to keep an eye on them so that they don't hurt you, because that's what they're probably going to do. And then perhaps knocking on the door or coming in the front door of the clinic is somebody with a notification from an attorney's office that I made a mistake. All this is sort of swimming around my head when I sit down with that patient with a cold. And when I think about what I'm going to do, what are the different incentives that I'm responding to? There's the quality bonus from the IPA and from our hospital physicians organization, and there's the esteem and respect from my colleagues in the practice. But who's sitting right in front of me looking in the eye is that patient. And within 15 minutes, because also standing outside the door is the vice president of ambulatory operations, who needs me to see a certain volume of patients and be efficient in my use of time, and I've got to get all this done in 15 minutes. How do I judge what to do? If this patient is really, really anxious and was treated last year by one of my colleagues with the all-curing Z-Pak for her cough, do I have enough time to explain the difference between viral infection and bacterial infection and the importance of judicious use of antibiotics? If that's fighting a narrative that she's already deeply embedded in, that doesn't match up with. Do I have time to show her a video about the importance of not overtreating with antibiotics? What if this isn't a cold, though? What if it's lung cancer? And this cough is something that's chronic. And she's got a history of lung cancer in her family, and her brother recently died of lung cancer, and she really is looking for an X-ray, if for nothing else than to set her mind at rest. All these things affect my relationship with that patient, which is the primary thing in that room. And sometimes there's an enormous temptation to ignore better prescribing practices and just give her the azithromycin, because she'll feel better about it. And you know what? She's going to be better in a couple of days anyway. When I was a medical student, is there anyone here from University of Vermont? No? Yay. If ever any medical student raised the question of malpractice or practicing defensive medicine on rounds or in analyzing a case, our faculty were pretty good at always saying the best defense against malpractice is to practice good medicine, which is a simple thing, but it's something to hold on to when you're sitting in a room with the patient and there's a lot of conflicting incentives and pressures around you. All these people who are looking over your shoulder, potentially scanning your medical record for your initials at the bottom of pages. And so I think it's a complicated fear, and it's a fear that never completely dissipates. And hopefully it isn't a fear that often interferes with the actual relationship with the patient. But everybody's got a story of something that happened to a friend of theirs from medical school, or a colleague from their previous practice, or somebody they went to residency with. And those stories become part of our narrative as practitioners, too. So what it really boils down to is, how is it possible for us all to be living in the same narrative? Is that possible? Where doctors prescribe medications and order tests judiciously. Patients respect the experience and training and judgment of their physician. And a collaborative work is undertaken to cure disease and promote health. It's that sense of collaboration that's the key thing. And it's really hard to accomplish in 15 minutes for a patient that you see 2 times a year. So that's my...
Thanks, Bill.
Hi there. I think I was asked when we did this panel not to address malpractice as a system, but rather whether reform in malpractice is a critical and necessary element if we want to fix this problem of overtreatment. And I think I was asked because I've been known to say in public places that I don't think it really is the issue at all. When doctors are asked in surveys, they always mention malpractice as the number one problem they see, the number one barrier they believe exists to fixing the larger issue that we've been talking about here, which is overdiagnosis and overtreatment. Doctors say, this is why I can't do it, because I'm doing it to protect myself, et cetera. And I just don't believe that's true. And I'm going to spend a minute telling you why, but I want to just make it really clear that this is not in an attempt to defend our current bizarre system that we call the malpractice system. It's a little like calling our system a healthcare system. Malpractice, as far as I can tell, in America is a scattershot, costly, contentious way to assign blame that does it in a completely, in an almost random fashion that cannot in any way achieve either of its 2 purported objectives. Its 2 purported objectives are, 1, to decrease bad care. And there's overwhelming evidence that even if you're sued 23 times because you're giving bad care, you're still not prevented from doing what you've been doing all along. There's very, very little curb on bad care by our system. There's huge evidence of that. The other is that it should compensate people who are victims of bad care, and that always seemed to me to be a little bit bizarre. 2 of us are in a car accident, we're riding next to each other, both of our knees are damaged in this accident. You go to one orthopedic surgeon, I go to another one. My orthopedic surgeon screws up, and I lose my knee. Your orthopedic surgeon does a great job, but you lose your knee. I get $10 million, tough. If we really care about a safety net for people who have been harmed or who suffer medical damage, of course we would be much smarter to use a system like the no-fault system in New Zealand. In addition, it's a little bit interesting to recognize that about 11 cents of every malpractice dollar goes to the supposed victims. So if we wanted to really help victims, of course, we're spending 90% of the money on something else. Not to mention that there's huge evidence that there is very little association between malpractice and payouts. For every case that gets paid out to a victim, there are probably at least 10 cases of true malpractice. Everyone in this room who's practiced medicine has done something that meets the definition of malpractice. I made a mistake, and in my best day, I wouldn't have done it. And it caused harm. On the other hand, for every case that gets sued, probably only 1 in 10 really was malpractice by our current definitions. So this is a crazy system that does none of the things we should want it to do and creates a tremendous amount of misery and harm. On the other hand, I would suggest that perhaps the greatest misery goes to the patients who 90% of the time lose and have to go through this whole thing again, being told this person really injured you, and then you end up with nothing. And that's, to me, is a really, really, really crazy system. So I don't mean to say we should, any of this has to do with we have a good way of working out these issues. If there was malpractice in the case that we heard about before, so what? That has nothing to do with this is a rational way to deal with errors in medicine. And I'm pretty sure it's not going to fix it so that in that practice they no longer do that. But even so, I don't believe malpractice is the issue, and I'd like to spend a minute telling you why. So first of all, I grew up at a time that there wasn't malpractice. And we had our own version of it. It was called M&M. And M&M was a way to humiliate you and shame you if you made a mistake. And trust me, we all were as afraid of M&M as we are afraid of malpractice today. And I just would challenge you to think, if we got rid of the malpractice system tomorrow, do you think that this overtreatment would go away? Nobody would order unnecessary CT scans? Of course not. So yes, doctors are afraid of malpractice, and yes, it's a pain in the butt, although mostly its problems are self-inflicted because we have an insurance company paying for us. We're not going to lose our house. We're not going to lose our practice. So the ways in which we internalize that somebody is accusing us of being less than perfect are self-inflicted wounds, I believe, mostly. Now, that's not to say there aren't troubles if you have to go through a lawsuit in 2 years of your life and all that stuff, but it's mostly self-inflicted. What are the real reasons for overtreatment? And by the way, whenever I say overtreatment, I should really be careful to say overtreatment and its Siamese twin, undertreatment, because the two go together. They're not separate. And I think it's much larger than that. Let's spend a minute on overtreatment, though. I think the real issues have to do with shame and fear and humiliation and risk aversion. Now, there are some positive incentives for doing things. We get paid more for doing more. And maybe those will go away after ACA or some version of it, although there's such entrenched resistance to that wants to reward doing things that I'm not sure how successful we'll be at that. But I don't think the positive incentives are the big things. I think the real things, if you think about it, are risk aversion. And what are we really afraid of? We're afraid of humiliation. We're afraid of being seen as the person who didn't know, that patient came back, the patient you saw, you had something and you missed it. They have to do with a little bit, I don't want to harm my patients. I'm sitting across from the patient and I'm really worried that, there's 1 in a million chance, and maybe there's a 1 in 100 chance that I'll harm the patient with my intervention, but I don't see that because that's going to be down the line and nobody will blame me. What I see is if I miss it, everyone will know. So there are many reasons why we're afraid of missing things. But where does that come from? Because as somebody said this morning, overtreatment is not the problem. It's a symptom of the problem. And I think if we want to fix it, we need to look at what is the real problem. What's the underlying source of it? So I'm going to go back to something I said at last year's conference, which is that the real issues are shared mythological assumptions that we all have in our society, that we have within the culture of medicine and that we have in the larger society, that we're partially responsible for, but not entirely responsible for. We heard this morning there were a couple of great books on the panelists. There's a lot of great books that have been written by people in this audience. Shannon's Overtreated, that I hope we all know about. Howard Brody, Lena Wynn has a terrific book. David Newman. There's a lot of people in this audience who have terrific books, and they're all about medicine and about the topic we're talking about today. But I'm now going to say something that may get a lot of you a little exercised. I'm going to reference a very different book. It's not about healthcare at all, but I think it's really, really, to me, it's one of the most important books ever written. It's by Edward Herman and Noam Chomsky, and it's called Manufacturing Consent. And it's not a book about medicine. It's about a book about how we as a society buy into all sorts of things that are really harmful to the vast majority of us because we don't question fundamental assumptions that we've been learning since childhood and which the powerful news media reinforces all the time. And when he talks about it, these are lefties. They're not talking about Fox News. They're talking about the New York Times. And they have chapter and verse of dramatic distortions of reality to help us continue to buy some of our assumptions. Now, I'm going to say something now that maybe will disturb some of you. Just to give you an idea, before I talk about medical assumptions, I want to spend 1 minute. What I mean by assumptions that we never challenge. Right now, there's this big issue about Iran getting a bomb. How many think Iran should have a bomb? Nobody? No, we all agree Iran should have a bomb, but how many times when you read this in the New York Times do you read, well, shouldn't we be asking, how come Israel has a bomb? Or even better, why is it dangerous for Iran to have a bomb, but not dangerous for America to have a bomb? After all, who's the only country in the history of the world that's used a bomb on civilians? We're the only country that says we'll use it again. We said that publicly. We could use it preemptively. So, with that notion, I want to suggest to you that the underlying things that we really need to be talking about is where do some of the critical myths in medicine come from? And I hope I got to stop, but those myths include more is better. Knowledge is power. Knowledge isn't power when it misleads you. More is often much, much worse in ways that we try to ignore. Where is the myth that uncertainty is bad? We never talk about uncertainty. We're afraid of it. We act as though it doesn't exist. Guidelines always have an answer. They say, we reviewed 7,000 articles. Most of them were irrelevant. The others were crappy. And here's the answer down to 3 decimal points. So I think if we really want to have this discussion, we have to get back to, and I'll just finally say that those myths come partly from us. We like the public to believe that we're godlike. We really do. Up until the moment where things go wrong and we say, wait a second, you'd expected a miracle? I'm just a person. And we often present that myth. But I think I heard this morning, much more important is that this comes from entrenched interests. And Diane Meyer said something about capitalism, which I think is really what we have to end with. That you can't serve two masters. We have a profit-driven healthcare system. I don't mean for-profit, because not-for-profit is very similar. I mean a healthcare system where the goal is not health, it's profit. And I don't think you can have both. Now, whether we can have that in the larger society is an even more important question. But at least for healthcare, we should admit that if we really want to address this, we have to say that undertreatment and overtreatment and all of this comes from a system which is not driven by the needs of patients or the needs of providers. It's driven by money.
Thank you, Jerry. So we've heard some really interesting sets of comments. We've talked a little bit about defensive medicine practices and some of the drivers of defensive medicine: profit, uncertainty, time, volume pressures, risk aversion. We've talked about our failure to really understand, to manage uncertainty, and to teach our fellow learners, students, residents, and everyone else who is learning along with us about how to think about and talk about uncertainty amongst our colleagues and with our patients and their family members. So would like to open up the floor for some discussion here about defensive medicine. What is it? What drives it? What can we do about it?
My name's Courtney Gustin. I'm a certified nurse midwife in Georgia. So working in OB, we always hear that it's the most litigated specialty and that you're especially at risk for lawsuits. As a midwife, I think patient empowerment and really making those patient-centered dialogues happen and informed consent are really important to us, and we kind of think, well, we won't get sued if we do that. My physician colleagues, though, say, you know, the procedure that goes undone or the medicine that gets unprescribed or the test that isn't ordered is what you get sued over. And so I struggle where I'll say to my patient, you know, ACOG says we should induce you at 39 weeks because you're a diabetic, and the patient says, no, I don't want to do that. And I write it in the chart and say, okay, great. And then I get a phone call that night and someone says, well, your patient's here and we see here that you told her she didn't have to be induced, and she does. And so we kind of go back and forth. And I'm wondering if you can address, you know, if that doctor had documented in the chart, well, I said to the patient he should find a nephrologist and he said no thanks, you know, what the difference would be there. Or if the doctor looked and said, you know, I assessed the situation and I think the risk is minimal, so I'm not going to refer him right now. How does that differ from, you know, making a mistake? Or how do you feel about that, you know, the procedure that isn't done is the lawsuit versus something that is? Because we see poor outcomes from unnecessary cesareans, but it really seems to be true that people don't sue over that typically. So,
Max, would you like to address that?
I can't see it because I'm blinded by the lights, but yeah.
So to speak.
I hear what you said, and I have a couple of answers to that. Number one, OBGYN. Now, I'm not as old as you are. That was before medical malpractice. But when I got into training, you needed to have 3 years of general surgery and 5 years of OBGYN. to become an obstetrician. Now, between the 70s and now, the specialty has grown about 300%. We had no idea about chromosomes and genes and, endocrinology, we used to call them pee boilers because you used to have urine that you warm up and then you look at the crystals to see if it's a levocrystal or a dextrocrystal. Now we have, all kind of testing. The specialty has grown 300%. The residency has shrunk to 4 years. So the question I don't have an answer is, or we were really stupid, or the new doctors are extremely smart. If they can absorb in half the time 4 times as much as we absorb, and they can work not every other night, but once a week, because now we cannot work more than 80 hours a week. I don't have the answer for that. But I know what that has created. What that has created is the following. When we get called from an emergency room in the 70s, the patient has abdominal pain. We go down, get a history, do an exam, blah, 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 and we spend time, and then we didn't have ultrasounds. In the early 70s, the stage 1 ultrasound was white is solid, black is fluid. That was the first generation of ultrasound. Now, a resident gets a call from the emergency room. I have a patient with abdominal pain. Get the beta subunit and an ultrasound and call me when you have the results.
That's true.
Okay? So we degenerated into what? Don't ask for a test to confirm or rule out a diagnosis that you worked up, but ask for a test and look for the asterisk. If it's an asterisk, it's abnormal. Then we look what entities can give you an abnormal test. That increases the price of medicine, doesn't it? The only problem is that when you do depositions and you ask the doctor, what's the normal range of this test? They give you the blank look, like, why are you asking me? Standard answer, it's different for all laboratories. Well, why don't you tell me which laboratory you are using? Okay? The other thing you can see is doctors, when you say one doctor writes one thing, the other writes another. People write a medical record, and they write, rule out ectopic pregnancy. Whom are you writing that for? You are the doctor. You have to rule out ectopic pregnancy. Don't write for lawyers. You don't know what lawyers are looking for. So people write, rule out this, rule out that. I'm thinking of this and that. Well, if you're thinking, do it. I like the answer in Vermont, practice good medicine. The only problem is that you heard it too, that you spent a lot of time thinking of who is behind, who is in the back of your mind. You can't do that. This means obstetrical cases, I'm inundated. We are the second largest practice in Massachusetts. And I cannot tell you how many times midwives and obstetricians disagree in the medical record. Why don't you disagree in the doctor's lounge or in the nurse's lounge or in the patient's room? No, they disagree in the medical record. That leads to litigation, self-inflicted litigation.
Jerry, you want to respond?
Yeah, I just wanted to say 2 things briefly. One is that we should be really careful about anecdote because there's always an anecdote that can prove anything. But I think there is pretty good evidence of what Beth said right at the start, which is that the generation of most malpractice cases, or the vast majority, is predictable on the behavior of the provider way back when they're first starting. Not 100% correlation by any means, but that it has a lot to do with physician-patient interaction and communication, and that it isn't about did you do the test or not. Now, I really believe it's true that practicing good medicine is by far your best defense. I also think we should realize that, like so many other things in life, we can't control everything. And the one thing you really need for a malpractice case is a bad outcome, and we're in the bad outcome business. That's what we do. We take people who all eventually have a bad outcome. And so the real question is, did you do something really terrible? And does your patient like you? Does your patient trust you? Did you talk and communicate with that patient? And so I think we're much more likely to avoid malpractice by being A, good doctors, and B, good communicators than we are by doing unnecessary things. And the last thing I'll just mention is something I didn't have time to go into, I really wanted to talk about, which is patient expectations. We have created in our society bizarre patient expectations. In the United States, we can do anything. We're the fix-it country, which means that death is optional. If there's if there's a bad outcome, that means somebody screwed up. So part of our job has to be, and this is partly in one-to-one relations with patients, but it's also partly us. When we go out there to try to fix this large problem that we have, one of the things we have to address is the disordered expectations we have created in this society. We and the people who are selling our healthcare system.
Thanks, Jerry. Please.
I'm Professor Emeritus of Medicine at Northwestern. I've had, I think, 7 or 8 different jobs at the same medical school over the years. Right now, I'm still teaching and still doing clinical research. I have a lot of experience. In fact, I was told once that I taught more medical students in house offices at Northwestern than in anybody else's in the history of the medical school. That by the dean when I retired. From seeing patients, that is. I think there has been something only mentioned tangentially in this whole discussion. As someone who was sued once and the case was dropped because they couldn't find an expert witness to testify against me, it took 3 years for it to be dropped. It was because I didn't biopsy somebody with 7-centimeter kidneys and a creatinine of 16, and he was 6'4" and weighed 210 pounds to start and was 170 when he first came to our hospital. And I didn't biopsy him because I saw no need to subject him to what was a potentially fatal procedure when it was obvious he needed dialysis. For those 3 years, I suffered all of the fears and all of the anxieties that all of my peers have suffered who have been through this experience. And I think the important thing that is necessary for people to understand, and I'm sure most people in this audience do understand it, is that when you enter the career of medicine, you don't do it for money. At least I didn't. I was full-time at a university my entire life. That says how economically wise I was. And when you enter medicine, you assume a certain relationship with people that is one of responsibility to them and one of responsibility to yourself to provide the best possible job you can. In taking care of them and in ushering them through to the end of existence. As I've often said to my medical students, there is no one who has ever lived who is living now who hasn't died already or will die soon, and that was covered already. The trauma to one's self-image, to one's pride of self, is amazing. I was one of only 2 physicians in the entire practice at Northwestern who got 100% positive ratings from his patients, 3 years in a row, and yet I was sued. I was a competent doc, I thought. I thought I was better than competent, I thought. I received prizes, so I'm supposed to be wonderful. And yet I was sued, and it took 3 years for it to be dropped. So the anxiety, just the feeling of hurt, the feeling of self-identification was an amazing problem. And I've heard this from every physician I've ever heard who was sued, had it dropped, or who lost a case. It doesn't make any difference. I've been an expert witness on many occasions. I've seen lousy medicine practiced. I've given depositions in some of the fanciest offices I've ever seen in my life, and they weren't doctors' offices, they were lawyers' offices. And I can tell you that there is a real problem here because we see in our emergency room, and I know you're an emergency room physician, we see CAT scan after CAT scan after CAT scan that is not indicated, that is being done. And when you question the ER docs in what our hospital administration loves to say right now, we're number 6 in the country according to U.S. News and World Report. My only comment to that was how bad are the rest of them under us. But we were ranked number 6 at Northwestern, and yet I see all these unnecessary CAT scans, all these unnecessary MRIs being done. And when people who have the subspecialty look at it and say, this wasn't necessary, in my own subspecialty of nephrology, I say, why are you dialyzing this totally demented old man who doesn't even recognize his wife and his kids? It's time. The answer, the family wants it. And the real reason is that we're afraid the family will sue us if we don't. So there is fear, there is trouble, and I don't think we should push it under the rug. I think we have to handle it, and I think we have to face up to it, and I think we have to say that when things are not indicated, they should not be ordered just to cover one's rear end.
Let me take a wild guess. You were always an expert for the defense.
No.
You were an expert for plaintiffs?
Both sides.
Now,
Either side, whichever I thought was right.
at the other side,
Yes.
at the other side
Yes,
of your being a plaintiff expert,
yes,
there was a physician
of course,
that had the same anxiety that you had.
of course.
Should that be a reason not to sue?
No.
Okay.
No. What I'm saying is unnecessary suits. And you've just said that over 90% of the suits were acquitted, of the defendants were acquitted.
Taken out.
And are you equating that defense verdicts are unnecessary lawsuits?
Well, many of them are. Many of them are. I'm also
You would
saying,
admit that some lawsuits are not appropriate.
and I'm also saying.
According to the Harvard study, it's about 14-1 that of the lawsuits that, and they used very liberal criteria for inappropriate, and they still found that for every one case that was sued, their claim was 7 other cases should have been sued, but
Right.
for every 14 cases that was sued, only 1 was appropriate. So certainly this is a scattershot relationship between
Exactly.
what gets sued and what's appropriate. And there are some cases that are clear malpractice that never get sued, and there are many cases that get sued that have nothing to do with malpractice.
We have to take the fear of it away in order to get at some of the overuse.
So you're suggesting that it's, I was trying to say that I don't think it's sufficient to get rid of malpractice to solve this
Oh,
problem
it's
of
necessary.
overtreatment.
It's a necessary
You're
evil.
saying something a little different. You're saying you think it's necessary because it is such an ingrained fear in physicians that if we don't get rid of that, we're fighting an uphill battle. And I think there may be truth to that. I think we could solve it in different ways because much of that fear is, I really believe, self-inflicted and unnecessary. But I hear you, it is a tremendous burden. Physicians treat it as a tremendous worry. And until we address that, we're
Correct.
going to have people be afraid to do the right thing.
I'm going to take the liberty of the moderator, and I want to move the discussion ahead a little bit. What I'm hearing is that we have these sort of circling parallel universes of suffering. And that's what is most striking to me, that both the patients and their families, and we, those of us who are subject to suits, are suffering terribly. Now, I would like to address that issue, because I think if we don't address the issue and its root causes and how to ameliorate them, we will not actually be able to crack the nut of malpractice. So let me take your comments.
My name is Michael Millinson. I'm a consultant, and I'm speaking here as an author of a book Dr. Hoffman has not heard of, called Demanding Medical Excellence, Doctors and Accountability in the Information Age, which came out back in 1997 about quality, safety, patient empowerment, medical informatics. And I'd like to say a few good words here about fear and loathing and shame, a couple of words in support of the medical malpractice system, and in support of patients. So as part of doing this book, I'd been a journalist with certain preconceptions about physicians acting on medical evidence, and then went back and looked at the medical literature and contemporary accounts in magazines, newspapers, et cetera, from basically the 1930s, 1950s on. So let's talk about some of the myths that you've perpetuated. So why wasn't there malpractice? Well, there was malpractice. Part of the reason that if you look in the 1950s, there was pervasive overuse, what was called commercial medicine. It was not stopped by M&M. It was never stopped by the American College of Surgeons. It was never stopped by the American Medical Association. Peers did not stop malpractice. But there was articles saying the reason for all these malpractice suits in the New England Journal is because doctors testify against other doctors. And it's sort of heartwarming for me to hear leftist doctors and rightist doctors agreeing that the real problem is outsiders are bothering doctors. And so you had malpractice. Your memories are mythical. You can look and you can find, and you see what good things in malpractice do. And by the way, I'm not disagreeing with you at all that the system is crazy. I am disagreeing with you that we could just take care of it ourselves. So you see, for instance, that the first study on medical error is done in the 1970s by doctors and lawyers because of malpractice suits. Guy, Dr. Mills, who's a doctor and a lawyer. They say, is it us making mistakes or is it the lawyers suing us? And they say, no, it's us, but potential compensable events are so small we don't have to change. You get the Harvard medical practice study in the 1980s for exactly the same reason. Medical malpractice is very high. Is it us or the lawyers? Well, it's us, not the lawyers, but again, they don't change. You get the Harvard Medical Practice Anesthesia Guidelines because they're being sued too much, and there's a TV expose on NBC. So again and again, the history shows you that they don't teach you in medical school and that the memories don't encompass is that shame, public shame, and malpractice, even though for individual cases it's not justified, has forced the profession to act on error where before they would not. And it's all first-person sourced. And then when you take a look to our current time, the American Medical Association believes the solution is caps, right? And you see that good events are not taken care of. So from a policy point of view, it would be nice if we talked about some of the solutions like Troy Brennan has talked about with evidence-based practice, immunizes you from suits, special courts, things like that. The system is broken, but it was never unbroken. There was simply silence, a code of silence. Yeah. Last point. It is very odd to be at a meeting where physician maximization of income apparently does not exist. Now, it may not exist among those in this room, which are a certain subset of American medicine, but while money is in fact an issue, there are nonprofit health systems that put the profit in non-for-profit. You will see a physician from Stanford talk in the 1980s about target income. If we're going to talk about overtreatment, we need to talk about physicians who in their minds say it's because of defensive medicine, but are influenced by financial considerations. And it is silly, just pure silliness, to rant about the terrible nature of bundled payment and all the rest of this, when the evidence over years and years and years talks about financial considerations affecting doctors just as much as it affects corporate folks, even if not any of the doctors in this room. A last personal note in favor of patients, and of course I agree with you about expectations. When I had to switch doctors because I switched health plans, I asked a physician friend who to take as my family doctor. And he recommended somebody who it turned out had been sued for malpractice a little bit earlier before I chose him as my doctor. I did not tell him that I knew that, and I still haven't told him, but I chose him as my doctor. So the question is, can we educate patients to be better? Yes. But we also need to be realistic about not the physicians in this room, surely, but the rest of you who perhaps are influenced by money and other issues. Thank you.
Thank you. Shannon, do you want to take that on?
No. Call me chicken. I don't actually want to derail the conversation, but I do want to inject an idea that I would love to see the panel discuss, but not right away. And that is that I have heard enough from physicians about the anxiety of being sued, and it is real.
Yes.
The feeling of worrying about being sued is not something that's made up. By the same token, blaming all of overuse on defensive medicine is not correct. It gets blamed. It's kind of, when I ask physicians what are the two main reasons, except this group, well, what are the two main reasons for unnecessary care, it's defensive medicine and patient demand.
And
And
sorry?
patient demand, those darn demanding patients.
Yeah.
But I want to ask another kind of question, which is, when you give something that does not offer benefit for the patient, or is unlikely to benefit the patient, as Jerry has said to me many times, the risk is still there. The risk of harm does not go away. And so, is it not unethical to give a patient something knowingly that you know offers no benefit, but still poses risk? And I don't think we should answer that question now, but maybe that's a question to raise.
We should answer,
When
yes.
there's nobody else who's interested in commenting.
Can I just say that I think it's more than unethical. I think it violates the very fundamental notion of what it is to be a profession. And if you actually think about what it is to be called a profession is a societal agreement between the group of people doing it and the society, which says you have all sorts of skills and knowledge that we need. They're really, really important to us, but which we can't get for ourselves. We can't just go on the internet and figure out how to do surgery. We need your help. We will give you all sorts of rights and privileges and rewards, including respect, money, autonomy. There's enormous things that we get as a profession. There's one thing you have to promise, which is that you put our needs first. You're going to be a fiduciary for us. You're not going to do what's in your interest primarily. You can do what's in your interest. It just can't be the first thing you do. You have to put our interest first. So when you do something that you know isn't advantageous to a patient, but it's in your interest, because you think it makes you feel more comfortable. You feel less like I'm risking somebody's going to blame me. Yes, of course, it's not only unethical, but it's a violation of why every one of us who became a doctor said to ourselves when we did that I really am here to put patients first.
So the ethical mandate persists.
I think so, and I think it's also true that there's overwhelming evidence that this doesn't help you. And for all the reasons you said, malpractice is mostly not about bad doctors. It's certainly not about covering your ass and doing more. It's about not talking to patients, and it's about a society that has these crazy beliefs about anything went wrong, somebody needs to be blamed. Many times there is somebody to be blamed, but not always.
Can we ask questions, or we are only here to answer?
No, you can ask questions, Max.
How much of the anxiety that everybody's talking about has to do with ego? How dare you challenge me?
It does.
And how much of that anxiety is kind of fabricated?
But it's more
It's
complicated.
fabricated by the insurance companies. When I was practicing medicine, still, I always asked, how come we have malpractice crisis when Wall Street goes down? We don't have malpractice crisis when the stock market is going up. It's because the insurance companies are having what? Their investment not getting the proper returns. Then we create a malpractice crisis, we increase the premiums, and guess what? Name me companies that have gone bankrupt providing insurance. Name me one that has gone bankrupt providing insurance. The anxiety is a little bit, your house can burn down, you better have house insurance. Do you have enough house insurance? Because if you don't, we'll prorate the damage. There shouldn't be any anxiety. If what you did you believe was right, let the defense lawyers fight the battle for you. That's why you're paying your malpractice insurance. There shouldn't be anxiety. It's ego. How dare you challenge me?
It's complicated, I think, though. It is indeed partly that. But there's so much in medicine that is gray there's so little certainty in medicine. There's always something else you could possibly have done. There's always room to second guess yourself. There's always room to be afraid you might have hurt a patient.
And some of that ego is not venal and it's not evil. Some of it is I have this self-image of that I really care and I work really hard and I'm trying to do what's best for my patients. And here's some lawyer who, in his interest, can't just paint the picture to the jury that I made a mistake, has to paint the picture that I was callous and didn't care and didn't think, and you did what? Did you do this deliberately because you were interested in harming people? Of course it's a challenge to our sense of self, and it's understandable why we take it personally.
Yeah. So what would be the impact of having a policy of full disclosure, transparency, and apology and upfront payment? What would that do?
We have it in Massachusetts, as you well know.
Yeah.
Last November, they came out with a new law
Yeah.
that apologies cannot be accepted in court.
Right.
And in return, physicians will have to acknowledge errors. Will have to acknowledge errors. I yet have to see physicians acknowledging errors. It's already a year and a month. And you cannot tell me that in a year and a month there have been no errors.
I don't think you've been privy to every conversation that's occurred. There are studies about this which show that at least in limited circumstances, one is from the VA system, so it may not be exactly appropriate, but the other is from Michigan, and both of them showed that when they adopted policies to proactively tell patients about errors, that the number of lawsuits didn't diminish, but the number of payout, the amount of payout diminished phenomenally.
Mm-hmm.
I understand that, and I know the story about Ann Arbor. It all started with Tom Goodhale at the Mass General, where he said, apologize to patients, so you will avoid a lawsuit. Now, how does that avoid an error? You may avoid a lawsuit.
But that's
You
what
may
we're
talk
talking-
to people and avoid the lawsuit, but that does not take into account that an error was committed. Let me give you back your own example about the car accident with two people having their knees injured. I'm in a head-on collision, September 18 of this year, Route 95 South. I am driving, my brother who is a physician sits next to me. We are in a head-on collision, he's taken to the hospital. He's dressed in a t-shirt, shorts, and sneakers. Gets to the emergency room, and guess what? They don't undress him and do a physical exam. They take a history. Oh, you're taking aspirin? CAT scan to rule out head bleed. Comes back from the CAT scan, my leg is numb. So they do an x-ray. Oh, I think you may have a very small fissure in the tibia. Let's get a CAT scan of the tibia. Okay? After $9,800 of tests, and
not
guess
much.
what?
That's
And-
like one test.
And wait a second. And wait a second. After $9,800 in tests, 4.5 hours in the emergency room, he wasn't undressed to do a physical exam. He didn't have a neurologic examination and got a bill for $1,490 from the emergency room physician who gave him Motrin. Okay? Now,
Okay, what am
you
I
have
supposed to
the
learn
two
from this?
people in the same accident. You are not surprised?
No, first of all, anecdote is really hard to know. You're
It's not an
telling your-
anecdote. It happened to me.
I wasn't there, so I
It's
don't
not
want to.
hearsay. I didn't hear it. I was there.
I don't want to presume what happened, but we're talking in circles. Yes, there is bad care. What we're talking about is how do you fix that? And I don't think that making a malpractice system that solves neither of its goals. It doesn't help people who have been injured, nor does it decrease bad care or error. It doesn't. There's great evidence it doesn't do that. If all of those are true, and it's tremendously inefficient, and it causes lots of suffering, why would we choose to use that? It's a little bit like saying, why do we have our healthcare system when other systems are 1/10 the cost and have better outcomes? I don't get it.
I tend to disagree with you.
I can tell.
Surgeons did not do sponge counts until they were sued for forgetting sponges in the abdomen.
Okay.
Surgeons did not do needle counts until they were sued for forgetting needles in the abdomen. Malpractice sometimes produces much better medicine than the articles, and I come from publish or perish, okay? So nobody has to sell me academia. Publish or perish. There are a lot of articles, there are a lot of things written. There is a place for everything. There is a place for malpractice, there is a place for education, and there is a place for apologies, there is a place for everything.
There's a place for holding physicians responsible, but that's different than our malpractice system.
Okay, hold on. I want to get some more people into the act. Alan.
As somebody who teaches medical students and deals with their initial uncertainties and insecurities, I think we can learn something from medical students about what drives unnecessary utilization of services. And I think we're talking, this is not a conference about malpractice. I think it's a conference about getting best care and what are the things that drive care that's not necessary or potentially harmful. And I'd like to bring the focus back to that a little bit, if I may. And Beth, you've alluded to this in terms, you've used the word uncertainty a lot. And I think one of the things that we want to get at here under the rubric of malpractice is the anxiety that comes with uncertainty. And I think that one of the problems that we have, and it's actually illustrated in your emergency room anecdote, which is that it wasn't just lousy care, it was their approach to decreasing uncertainty. Rita Redberg here wrote an editorial in the New England Journal that was criticized by, she tells me, by the ER doctors. Her editorial was criticized because it wasn't sensitive to their concerns and anxieties about missing something in the ER relevant to the care of patients with chest pain. And although her editorial, I was very proud of her, she was one of my students, and I said to my wife, this is great. One of my students wrote an editorial that's criticizing the lead article in the New England Journal. What courage and what thoughtfulness. But the critique that she experienced is something that I think goes beyond just the fear of malpractice. It is good people dealing in positions of high uncertainty, which is psychologically very difficult, and they're trying to minimize that uncertainty both for themselves and for the patient. And we're not talking now about just doing unnecessary hip procedures and other stuff like that. That's another category. But this is the one where malpractice and physician insecurity and uncertainty and the inherent inability to predict or to understand what the probabilities are at the moment intersect. And I think if we don't address that, then I think we're going to miss a very big part of this. The malpractice part has a lot to do with relationships, and Massachusetts experiment is way too early to draw a conclusion that apology does not work, because we all know from the literature that patients don't sue doctors who care. They sue people who don't care. Absolutely. And one of the ways they don't care is they don't take a good history, they don't look the patient in the eye, they sit at the computer. That's not the issue right here. The real issue, I think, that the nut to crack, I don't know the answer to this, and my students ask me, how can you be more confident? What tricks do you have to understand the probabilities better? And I think if we can help our students in that moment and help the ER docs in that moment and understand their anxiety and their need to be more secure in their decision making, that will help us eliminate a lot of the other stuff. Okay. And that can be data driven, by the way. For example, Rita's critique was that the extra test did not actually change the probability estimate. That's very good. That's very important information.
Can I ask you a question? Do you think, because you seem to be suggesting that the way to fix this is to sort of teach about numbers, and it seems to me, I'm just wondering whether you think that, what's the role for, instead of what's your secret of how to be more certain, that the real secret should be that we change the culture to acknowledge that uncertainty is part of what we do, and that we will never be completely certain, and that it's as Jerry Cassira wrote in his famous article years ago, that it's a quixotic quest for certainty that is always and predictably self-defeating and harmful to patients.
Well, we don't need certainty.
Learning to speak to patients about uncertainty?
Exactly.
That's
Speak
what
to
I
them
would like
about
to have some discussion about that. if we could.
Exactly, and that's what I say to my students, is share what you understand with the patient and try to come to a shared strategy going forward and weighing the pluses and minuses of different approaches. But I just want to put on the table, again, I don't have the answer, and I'd be interested in the panel's additional thoughts. This particular element of what's driving behavior, malpractice, I think, is only a subset and maybe a smaller amount or a larger amount, but it's the uncertainty part
I agree.
that is very powerful.
But can I tell you one thing? Can I ask you one thing or tell you one thing? How many doctors do you know that tell the patient, I don't know what's wrong with you?
I think that's a... let me say something
Okay.
about that, because I've been listening to you, and I want to tell you,
Oh
that is
boy,
that
here
is
comes,
not
here comes the shooting.
that is
Why
not
would we ever
I'll
say
protect
that?
you.
that is not this generation, and it may have been another generation, it may have been your generation, but it's not mine. That's not the manners we were taught. We were taught a very humble approach, and not one of the doctor is God. So I think that's gone. That's sociologically over with.
Let me tell you what I wrote here, and this I wrote in advance. I said, arrogance gets you sued.
Yes.
One dose of humility, BID, keeps the lawyer away. Did I send that?
Yes, you did.
I sent it weeks ago,
Yes,
didn't
you
I?
did. Yes, you did.
Let me add something about that uncertainty,
Please,
because I
Bill.
think that's an enormous principle. You know, we're all trained as physicians from an anatomical, pathophysiological point of view. We don't hear about Bayes and probability until relatively late in our training. And I think it's difficult for most physicians to talk probability and statistics with their patients because it's a little foreign to us.
Yeah.
And perhaps if we started learning about positive predictive values and likelihood ratios from the very first day of medical school and grew up in the comfortable environment where we'd be used to speaking about those, it would make it easier to talk with patients. There's a terrific set of tools that Victor Montori at Mayo Clinic has put together for help explaining risk to patients that are very visual. You know, smiling, happy faces for avoiding heart attacks, frowny faces for heart attacks, compare with statin and without statin. It's a lot easier to explain these concepts to people, and it's a lot easier for us to understand them the same way. We just don't have a good way of incorporating that into our wholeness as physicians.
Those are shared decision aids, patient decision aids. Let's go to, I think we have time for one more question. Sorry.
Well, there are several really good people behind me. I hope we have time for more than one. But I'm struck in this conversation. I'm Helen Haskell, and I'm from Mothers Against Medical Error. And I have been through the system, and I have lost a child to unnecessary care. And I am struck by this sort of underlying assumption of this conversation, which is one of the medical myths that has been promulgated with great success, that malpractice litigation is something that is generally unnecessary. It's sort of volitional. People do it whether they like you or not. That's not really the issue. The issue is patient harm. People sue when they are harmed. What I have seen, and I have heard thousands of patient stories at this point, and in general, the unnecessary care is not something that starts out at the beginning. It's part of a cascade that begins with perhaps, as in some of the stories you heard this morning, perhaps one snap judgment that leads to more and more things that are really inappropriate, incidental findings on X-rays that should not be acted upon, so that you end up with people who are really terribly damaged, who have terrible financial, social, personal consequences that are far beyond feeling like a professional failure. That's what it's about. And I would say, from my knowledge of other countries where we don't have the system, you have the same amount of secrecy. It seems to me that it's driven by professional pride, not by money. I see it almost identical in other countries, except that in our country, it's more open. And I attribute that to our more open litigation system. There is an inclination to disclose when you fear litigation, the same way that you would disclose that your basement tends to flood to a prospective buyer. There is pressure to disclose risk, and what we hear about is trying to get people to recognize that, to do that more, because medicine has been really insulated by malpractice insurance, by medical malpractice caps, by many things from the consequences of not disclosing. I mean, to me, transparency is the solution to all of this. I mean, that's the patient advocates'
Thank you.
perspective.
Thank
Can
you.
I ask for a show of hands? I have one question, just one question. Tomorrow, we do away with medical malpractice. We tell the lawyers, go do divorce, go do whatever. Okay? We do away with medical malpractice. How many of you think that there will be less errors? How many of you think there will be more errors? How many of you think patients will benefit from that? Maybe medicine will get a little cheaper if you do less defensive. I think bad doctors practice defensive medicine, but that's my opinion. But how many of you think there will be less errors if today we kill all the lawyers and no more lawyers?
Well, that's shelving a lot of errors right there.
How many? How many? I don't see too many hands.
Well, errors will persist. I think
How
that
many
the-
think they will go up? That's correct. As the system goes now, as it is now. You take away the lawyers and the medical malpractice. How many of you think patients are going to get harmed more often? Well, errors. Errors that harm patients.
Well, may I comment briefly? I know
Please.
we were supposed to be out of
We're
time,
running
but
out of time, so we have to,
so
be brief.
it is almost directly to this point that I wanted to speak, because I want to lob you a softball. First of all, I think Michael's comments were brilliant. It is really important to remember that there was a need for this system to begin with, and that it probably did have an important effect. It's now corrupted and wrong, and things aren't working the way it was supposed to work. Dr. Borton, I mean, you trained in a time, what was it, 5 years of general surgery and 3 years of OBGYN, every other night call. I can understand why you sue doctors for a living at this point. It makes all the sense in the world, and really, it's all coming together for me.
This comes from medicine, not from the law. Okay.
Oh, all right. But I point this out because, here we are talking about, it's funny, we spent the morning talking about, like, cases where you can look at those cases and you can see, wow, this system failed. This system failed the patient. And then we get a little huffy when we hear about malpractice and basically some kind of check on the system. Now, the check on the system isn't working, but we have so many patient experiences where the patients are failed so miserably. And your example of a case was a case where the system failed. Yeah, you can point out 7 or 8 little individual failures in the case that you presented. Somebody didn't read the whole letter, a 2-page boring letter from a surgeon. I'm not even sure it's going to be literate half the time, so I don't know that I would get very excited about reading it, but maybe I should have, and that would be malpractice. And maybe, on the physical exam, I should have gone back over 10 years of records on this child. All of those things just seem like system failures to me. A system that feeds the information the correct way, where when there's proteinuria media. It's not, buried in, the second page of a surgeon's 2-page letter is a system that would fix all of this. So here's my softball question. We have a system right now where we all know that we're failing patients on a daily basis as a system. We're looking at it and hearing the stories and going, wow. I mean, in a way, we want that to be malpractice. Somebody should get sued for how crazy that is, right? And yet, we don't want the lawsuits. Why? Because the lawsuits couple the failure with the personal responsibility of a physician. That's what's happening, and that's what's ticking everybody off, and it doesn't make sense. Because 99% of errors and problems and failures in these systems are system errors and not human errors on an individual moment-to-moment scale. So is there a way that we might be able to keep what's good about malpractice and the check on the system by not having it coupled individually to a physician's pride or ego or single event or moment of doing or not doing? Can we
So-
uncouple the personal responsibility?
You're raising the issue of a no-fault system, much like exists in New Zealand and some of the other
Not
countries.
quite.
I think
so.
even
I
more
don't
than
think
that,
so.
what I'm hearing is what in industry would be called creating an environment of continuous quality improvement, where you focus specifically on the system and not on individual errors. And it's really hard. It's very hard to enter a risk report. If you see something go wrong, you think, oh, I don't want to get so-and-so in trouble, or, this is... But
But I don't think systems are ever going to be able to fix problems in interpersonal communication. I'm sorry. I
Oh,
think
absolutely not.
Was
it's
the
more,
softball for me?
it's complicated, but this is a huge question with multiple layers to it. So there's never ever going to be one simple fix. And system fixes, quality improvement, everybody's all for it. But it's
Right.
not the only solution.
But you see, I think that I have a comment to make. When the traffic controllers launched a strike with Reagan, he replaced them all. Correct?
He did.
If physicians refuse to see patients every 5 minutes because your manager is outside the door or somebody tells you what to do, physicians cannot be replaced. Okay? So I think that in part, they mentioned here Supreme Judicial Court. I argued the lost chance case in Massachusetts. And I asked the physician, why did you sign that contract when you knew you could not practice good medicine? And the answer was, because if I don't sign it, somebody else will sign it. Mm-hmm. And that lost the case for them. Okay? I don't want to get into the case, but what I'm trying to say is the following. If physicians will stop and think, I want to practice good medicine, and it takes 20 minutes per patient, and I will not go and do 15 minutes or 10 minutes because some administrator tells me, a lot of the problems can be diminished.
No, I agree with that. One last question, Rosemary, and then we're going to wrap up.
Is this on? Hi, I'm Rosemary Gibson. I was at the Robert Wood Johnson Foundation for many years and led our palliative care national effort, and thanks to Diane, made it possible. I also got into the safety world by writing the book, The Wall of Silence, which put a human face on errors and treatment trap on overtreatment. Just a word on safety. I've come to the conclusion after 13 years that I think we're making it impossible for even the most competent physicians and nurses and others to practice care safely because of the volume issue. I think it's just impossible.
Yes.
And all the stream of new equipment
That's what I
and new
said.
devices.
I agree.
I think it's impossible to do it safely. But back to the overuse, and maybe Jerry, this is for you. Why isn't there fear and loathing among physicians that are doing unnecessary stents? Why wasn't there fear and loathing at Reading Hospital, in Elyria, Ohio? Why wasn't there fear and loathing in Towson, Maryland, when 583 people got stents who didn't need them? What is that all about? What's the reality that's constructed?
You know, it's obvious that this is a very complex issue and that we're doing little sound bites, and you can't cover all of it. And so, for example, people seem to be confusing my comments that I think this system doesn't fix anything, this malpractice system. It's very scattershot and doesn't doesn't actually decrease errors or help patients, into saying doctors shouldn't be responsible. I think those are very different things. Now, you're asking, getting back to the issue that we were supposed to be talking about, which is what are the drivers of overuse and how does malpractice say into that? And again, it's very, very complex, the basis for why people do certain behaviors and not others. And we don't have time to talk about all of them, but certainly getting rewarded is one of them. The Choosing Wisely campaign, the cardiologist wrote 5 things, and they forgot to mention $4 million a day of unnecessary stents. They mentioned we shouldn't be doing hangnails anymore. Let's not do that.
Right.
So yeah, there are a lot of reasons.
Where's the big stuff?
Yes, but I think to give doctors their due, and I've taken the podium many times to be critical of doctors, but to give them their due, to the extent that it's not just venality, I think it's a human nature of, I'm afraid, I don't know what's going to happen, I will be blamed if X, and almost always you're going to be blamed more for omission than commission, particularly if the commission doesn't happen tomorrow. So if I do a CT scan and a person gets cancer 10 years from now, who's going to know about that? But even if I did a stent that was unnecessary tomorrow, I warned the patient, look, this is part of the complications. 1% of the 3% you get this. And so I can defray blame, and that's personal blame as well. It has nothing to do with malpractice. It has to do with feeling bad about myself as a person when I do things for commission. But you didn't get that test? What were you thinking? It's very hard to feel good about yourself after that. I think it really all comes back to what was said before about uncertainty. We have to start addressing the notion that we can't fix everything and that there is uncertainty, and we have to be open about it to ourselves as well as to our patients.
So I'm going to sum up just for a second. I think we've raised more questions, of course, than we've answered. It's a complicated issue, and I think that it's been said over and over again that what we really need is better education for ourselves, for our fellow learners, about open, honest discussion and collaboration and care. Caring about the patient, not just doing things to the patient, and that we need curricula for ourselves, for everyone, really, from the very beginning of training, and how to manage uncertainty and really communicate more effectively so that we can really partner with patients, let them know what we're thinking, be transparent about what we don't know and do know, and have them work along with us to co-create some kind of a reasoned pathway forward.
Thank you. I'm going to offer those who have questions to continue, but I did want to just make a 2-minute break to say there are refreshments outside. We will reconvene at 3:35. And Lena Wen is still doing filming. I saw earlier filming going on. Now it's moved to the Tremont room, so if you haven't had your chance, here it is.
Thank you. No. I don't think so.